Hi, I'm Dr. Suzanne Lippert, and I will be lecturing today on altered mental status, and this is part 2 of 3. So our objectives for the lecture today are to really understand that altered mental status is most often multifactorial, that these patients should, again, be considered sick until proven otherwise, and that they are dynamic and require frequent reevaluation. So let's review our case. We have a 62-year-old who's a known alcoholic, and he was found walking unsteadily and was combative, and he arrived in your emergency department somnolent. He was found to have hypoglycemia to 46, and you treated him with D50. He became more alert, his diaphoresis resolved, his glucose increased to 120 on a subsequent check, but he remained confused and so only had a Glasgow Coma scale score of 14. His heart rate improved from 135 to 122, but he remained tachycardic, and he remains tachypnic with a respiratory rate of 20. So it is now time to really reevaluate in more detail. On this reevaluation, we want to begin with obtaining a sample history and a physical exam. We'll then go through the differential diagnosis and different ways to organize your thinking around the differential diagnosis for altered mental status, which is, again, very broad. And finally, we'll talk about appropriate diagnostic testing in this particular patient and immediate treatment. So our sample history. We start with symptoms. We need to obtain an allergy and medication history, a past medical history, the patient's last meal, and any events surrounding the present clinical presentation. So let's start with symptoms. Obtaining a sample history in an altered patient is challenging, right? Just think of our patient. He's 62 years old. He's confused. He's aggressive. He has slurred speech. And then he alternates that with just being somnolent. After he does improve, when we've given him the dextrose and he's more alert, he also reports that he's had some nausea and vomiting over the past 3 days. When he first arrived, he was really unable to provide any history. So you really have to look to family, to caretakers, to just even witnesses or the paramedics who bring him in. There's a lot of detective work involved in obtaining, even the most basic elements of your history in altered patients. One of the things that is important to obtain is, well, what's this patient's usual mental status? If you are able to talk to family, how does this clinical presentation right now differ from that patient's usual mental status? When did the change occur? How quickly did the change occur? And were there any specific events? Did they have a change in their medications that precipitated this change in their mental status? Again, there's a lot of detective work, and you have to look for alternative sources of information rather than just the patient. Also, extremely important is to obtain a history of any allergic responses they've had or any medications they're currently taking. So you can see these are some of the medications that are known to be implicated in altered mental status. Anything that may change your glucose level, antihypertensive medications, thyroid medications, psychiatric medications, anticholinergic medications, narcotics or benzos. All of these medications and medication classes can cause pretty severe altered mental status. And then, of course, there's the most common medication-related cause, which is just polypharmacy. Lots of patients are taking 7 to 8 to 9 medications a day. And not only can they have interactions with each other, but the patients can become confused and be taking things in error. So the past medical history, also extremely important, because many medical conditions actually, when they are decompensated, result in an altered mental status. Let's just think of some of the top ones. Diabetes, of course. Someone who is in DKA or is hypoglycemic can be extremely altered. Someone who has thyrotoxicosis, their thyroid level is too high. They basically can also result in agitation and be very confused. Adrenal insufficiency, malignancy, and any number of paraneoplastic syndromes can cause altered mental status. Epilepsy, so patients who are post-ictal. Psychiatric illness. These patients, again, if they're in a decompensated state, may be very far off from their baseline mental status. And think again of the medications they may be taking. And then chronic renal insufficiency, hypertension, cardiovascular or cerebrovascular disease, all, when they're not controlled, can result in altered mental status. And finally, of course, substance abuse, both someone who's actively using or someone who is in withdrawal from substances. So returning to our patient, when he came in, he really wasn't telling us much. We just knew what the paramedics told us, that he was walking unsteadily, that he had slurred speech. Now that he's a little bit more alert, we also now find out that he's had nausea and vomiting for about 3 days. He does not remember, doesn't report any allergies or medications. He has a known history of alcohol dependence, doesn't know when he last ate, and as provided by the paramedics, he was found with an empty bottle of alcohol, combative and ataxic. So again, it can be very unsatisfying, and you may not have much of a history to go on when you are evaluating an altered mental status patient. So that's where we move on to the physical exam. Now, there are really 2 instances in emergency medicine where we perform a much more comprehensive exam. Because as you've seen in many of the other lectures, we really try and provide a focused physical exam. But in trauma and in altered mental status, we do a much more comprehensive exam. Clearly, we need to evaluate the patient's neurologic status. But we also want to look at their head, ears, eyes, nose, and throat exam. We want to look at their skin and their cardiovascular, pulmonary, and abdominal exams. It's just a much more comprehensive exam. So let's go through it in a little bit more detail. When I'm evaluating an altered patient on the neurologic exam, we've already done some of this. We basically evaluate their level of orientation, and we get a score on the Glasgow-Coma scale. Our patient was initially 12, and after his hypoglycemia was treated, he became a 14, with only 1 point off on the verbal score for confusion. I'm looking for facial symmetry, and again, the things highlighted in blue is what our patient had, and everything in white was normal on his exam. So his face was symmetric, his cranial nerves were intact. He was moving all 4 extremities with equal strength, and his sensory exam was intact. He did have slurred speech and an ataxic gait. He has normal reflexes and no asterixis. Any abnormality in this exam can actually really point you to, as they have taught you in your neurology rotation, the location of the lesion. And what if this patient's obtunded, right? I mean, our patient came in and he was somnolent, and some patients are not going to respond at all to you. But, you still characterize their level of consciousness. You can still give them a GCS score. You can check their pupils and look for symmetry. Again, do they have any kind of symmetric extremity movement or symmetric tone and reflexes? On the HEENT exam, I am always looking for signs of trauma. So a battle sign, raccoon eyes, or hemotympanum that may indicate a basilar skull fracture. Really, any kind of external signs of trauma around the head and neck are important to find on your more comprehensive exam. With the eyes, I'm looking at the pupils and then also looking at the patient's fundi, if possible, for any evidence of increased intracranial pressure. At the throat and mouth exam, again, assessing for any kind of impending airway threat, making sure that the gag reflex is intact so that the patient is adequately protecting their airway. And I'm also, basically looking for any kind of odors that may indicate that the patient's ingested something. And our patient smelled of ketones and alcohol. When I'm examining the patient's neck, I look for signs of thyroid disease, so any kind of goiter, and also assess for nuchal rigidity that may indicate meningitis or other type of cerebral infection. The skin and extremity exam is often neglected in a lot of the different chief complaints that come to the emergency department because it doesn't really hold that much valuable information for those chief complaints. But on altered mental status, the skin is extremely important to examine. It can help us identify particular toxidromes, right? So if the patient is diaphoretic or very dry, that can actually push us to think about anticholinergic or cholinergic toxicities. We look for temperature. So if the patient is extremely hot, you're thinking about heat stroke. And then, of course, rashes and petechiae. So thinking of bacterial meningitis, but then also of platelet dysfunction or other coagulopathy that may actually place the patient in a higher risk category for intracerebral hemorrhage. I look for coarse, dry hair or thinning hair that may be indicative of thyroid disease. And then, as you can see in the picture, and what corresponds to our patient, is we see spider angiomas. He's slightly jaundiced, and he has some palmar erythema, all of which indicate a likely liver condition. Again, I'm looking for medication patches, and then also assessing the extremities for edema that may indicate third spacing from liver disease, renal disease, or congestive heart failure. On the cardiovascular exam, I assess for the sufficiency and symmetry of radial and DP pulses, for the patient's rhythm and their rate, for murmurs, rubs, and gallops. Now, cardiovascular disease is unlikely to result in altered mental status by itself. It can be an indicator of the patient's severity of illness, however. So it's extremely important to get a sense of how hard they're working at this moment. And then certainly, as we were assessing for in our initial exam, we're looking for any condition that may cause hypoperfusion, so dysrhythmias or any type of shock. Similarly, the pulmonary exam can give us an indication of the disease severity. Pulmonary conditions are unlikely to be the sole cause of altered mental status, but they certainly can contribute. And again, as we assessed in our initial assessment, we're looking for anything that may cause hypoxia or hypercarbia. So looking for signs of chronic pulmonary disease, a barrel chest, clubbing, cyanosis, or acute pulmonary disease, the crackles of an infiltrate or pulmonary edema. If we have decreased breath sounds of a pneumothorax or significant effusion, if you hear wheezing. And of course, the oxygen saturation, which we again assessed initially, but is good to reassess at this time. And our patient had an abnormal respiratory rate. Again, even though his lung sounds and his pulmonary exam is quite normal, the abnormal respiratory rate can give us an indication of a different disease process. And this should trigger you to think about acid-base disorders as well, right? Because the patient may be compensating for acidemia. The abdominal exam. Inspection, we find that this patient is distended. I'm listening to make sure that he has active bowel sounds, which he does. Palpating. He has no tenderness or peritoneal signs, but you do discover a fluid wave. And a rectal exam. The patient has brown stool with no blood. The abdominal exam, again, is filling in for you some of the history you were unable to get from the patient. Right, with the distension and the fluid wave, we're already again thinking now about any disease process which may cause third spacing and ascites. So let's talk about the differential diagnosis. As I mentioned before, it is extremely broad and it is filled with life-threatening etiologies of altered mental status. So there's many ways to organize it, and I encourage you to develop your own systematic way of going through the altered mental status differential. But I'll offer you two that I use. The first is to simply go through your differential as you're going through your more comprehensive exam. So it's essentially looking at the differential from the viewpoint of a head-to-toe exam. So as you're examining the head, thinking about traumatic brain injury, thinking about strokes or central nervous system infections or masses, thinking about Wernicke's encephalopathy, seizures, or cerebral vasculitis. Again, it's an extensive list that this is not a complete list on the slide, but it's just to get you thinking about potential causes that really are kind of located in the brain or head. Examining the mouth. As we move down in our exam, really I use this as a chance to think about medications, toxicities, and substance abuse. So anything the patient may be taking in through the mouth. In the neck, I use that as a chance to think about thyroid disorders, parathyroid that may result in hypercalcemia. I move on to the chest or cardiovascular exam and think about causes of hypoxia, like pulmonary embolism or pneumonia. Think about hypercarbia that may result from decompensation of COPD. Thinking about dysrhythmias or shock. Moving on to the abdominal exam, again, looking for any stigmata or signs of liver disease, any signs of renal disease or electrolyte abnormalities. I think about, adrenal insufficiency and other endocrine disorders. The pancreas, so diabetes or pancreatitis. Thinking about severe infections and peritonitis or mesenteric ischemia or AAAs. And on the skin exam, I think again about bacterial meningitis, about hypo or hyperthermia. And I use it, to really, as I'm examining for rashes, thinking about all of the differentials that can go with rashes. So TTP, again, bacterial meningitis or vasculitis. Another way of organizing your thinking around altered mental status is to use this mnemonic, AEIOU tips. So with A, I think of alcohol, toxins, and drugs. E, endocrine disorders or electrolyte abnormalities. I, insulin, which just really prompts me to think of diabetes. O for oxygen or opiates. U for uremia, renal disease, and hypertension. T for trauma and for temperature. I for infection. P for psychiatric disease and porphyria. And S for subarachnoid hemorrhage, space-occupying lesions, and seizures. These are just two possible ways of organizing this immense differential. And again, I really encourage you to develop your own particular way of organizing your thinking around the differential so that you can go through it in a systematic way and not leave out any of the possibilities. If you don't think about it, you certainly won't test for it and you won't find it. So how do we narrow this immense and broad differential? Well, let's think about the history we've obtained on this patient, right? He may have had a recent alcohol binge, given that he had this empty bottle of alcohol. He has known alcoholism, and he reports that he's had some nausea and vomiting. So again, maybe there's a component of intoxication that is making him somnolent and ataxic. But again, if someone's had a recent alcohol binge and they were quite intoxicated, I also keep thinking about possible traumatic injury from falls or assaults. So this gentleman was quite combative when he came in. It's entirely possible that he could have been assaulted. Knowing that he's a chronic alcoholic, I also really think we need to keep Wernicke's encephalopathy on our differential, or that he may be going into alcohol withdrawal as his agitation increases. On physical exam, we found him to have a high heart rate and respiratory rate, slurred speech and an ataxic gait, a fluid wave in his abdomen, spider angiomas, and a ketone odor. So the physical exam has given us a large amount of information to work with. Many of the findings, the spider angiomas, the fluid wave, and distended abdomen, point to possible cirrhosis. And frankly, hypoglycemia also supports that. So now, other things that are increasingly likely on our differential are hypoglycemia, alcoholic or fasting ketoacidosis, a poisoning from a toxic alcohol, coagulopathy, right, which may have led to GI bleeding or intracranial hemorrhage, hepatic encephalopathy, spontaneous bacterial peritonitis, hepatorenal syndrome or uremia, or pancreatitis. Still a broad differential, but ones that we can connect back to the pathology we're finding on our history and physical exam. There are a few red flags. He definitely continues to have a high heart rate and respiratory rate despite our initial fluid resuscitation and our correction of his hypoglycemia. We also smell a ketone odor. Okay, let's now talk about the diagnostic testing that we would like to obtain. So listed here are some of the tests that we often order when confronted with an altered mental status patient. I'll let you look at those for just a minute. And then these are the tests that I would most certainly get in the case we are discussing. So on our differential, we still have a possible infection. So a complete blood count may actually support that with an elevated white blood cell count. But it also gives us information about the patient's synthetic activity of his liver. So looking at his platelet level, does he still have synthetic function? We get a comprehensive metabolic panel to make sure that his electrolytes are not quite abnormal. And we can see from that as well his liver enzymes and his renal function. We should obtain a lipase. He's reported nausea and vomiting, and he has a risk factor for pancreatitis. So that will help us rule that possibility out. And serum osms. Now this is extremely important to determine whether this patient has the possibility of a toxic alcohol ingestion. We have a high suspicion for ketoacidosis given our finding of a ketone odor on exam. The urinalysis will also help us by demonstrating ketones in the urine. The lactate can be used as a marker of illness severity. Certainly if he has an infectious process, we would be concerned about sepsis if his lactate was elevated. I also chose the ammonia level because of his level of somnolence. He has stigmata of chronic liver disease and is therefore at risk of having hepatic encephalopathy. We can check toxic alcohol levels, particularly if we find an osmolar gap or an anion gap acidosis. And then in anyone who is this tachycardic, I usually check an EKG to ensure that it is truly a normal sinus tachycardia. At this time, there doesn't seem to be an indication for any type of imaging. There was no evidence of trauma on the patient's head, and he really became much more alert and appropriate after treating his hypoglycemia. That being said, it is not completely out of discussion as to whether or not to obtain a CT scan of this patient's head. He is most likely a chronic alcoholic who, again, may suffer from brain atrophy and be at higher risk for hemorrhage from bridging veins. So, not an unreasonable test, but again, in our exam, there's nothing to support a traumatic injury to the brain. A toxicology screen, also not completely out of discussion, but we can gather from our extensive exam that we don't see a particular toxidrome in this patient at this time. Okay, so some of your results have started to come back. The urinalysis reveals ketones in the urine, and the electrolyte panel shows a CO2 level of 12, an anion gap of 23. There were other small abnormalities in the electrolytes, but these are the most notable. You have a high anion gap acidosis. So we really need to consider, particularly in this patient, a toxic alcohol ingestion. So we did actually send that lab and we see no evidence that he's actually ingested any of the toxic alcohols. We also need to rule out lactic acidosis from sepsis or hypoperfusion. We sent a lactate, and that has also come back normal. It's extremely unlikely that this represents DKA, or diabetic ketoacidosis, given the patient has no history of diabetes and his glucose was 46 on arrival. And we've also thought about uremic acidosis as a possible cause of this high anion gap acidosis, but his creatinine came back normal as well. So this really leaves us with the most likely etiology being alcoholic ketoacidosis. So as I sum up this portion of the lecture, I want us to revisit really what I want you to take away from this. I want us to identify and treat the life threats and reversible causes of altered mental status. And you can see that in our initial assessment, we were able to actually treat an easily reversible cause and significantly improve the patient's clinical picture. We need to obtain a bedside glucose measurement on every altered patient. We have even seen in this one example, altered mental status is most often a multifactorial illness. So there's many causes acting on the patient at the same time. And these patients are sick until proven otherwise, and they are rapidly changing, so they're quite dynamic and require frequent reevaluation.